Hey guys, this is Brandon McGee at the McGee Law Firm, where we focus on estate planning and elder law. And today we're going to have another episode of Interview with the Experts. And I'm really excited about this one today. I have with me Mr. Reggie Nworka, and he has worked in home hospice for the last several years. He's a registered nurse, and I did not know Reggie before today. I just had a chance here, the last half hour to talk to him. Get to know him a little bit. And I'm really fascinated by this topic because, what I do for people, Reggie, is I help set up the paperwork so that when somebody passes away or becomes mentally incapacitated, the family has the easiest time possible. And then on the tail end, after the person passes away, sometimes there's some work we need to do for the family to help out with that, to transfer the assets. But what fascinates me is what you're doing. You're there in the middle between what I'm doing, and you're actually working with the individual and the family as the person passes, correct?
Right.
Okay. So tell us, just kind of generally speaking, give us a little bit about your background and what led you to this path of home hospice.
Right. My name is Reggie Nworka. I'm originally from Nigeria. You can tell from my accent already that I'm originally from Nigeria. I studied to be a doctor, but life happened at some point. I lost my father, who was my benefactor, and I could not continue to medicine. And I ended up working with the World Bank, a part of the United Nations system. When I came back to the US and decided to get back to healthcare and became a registered nurse, and in memory of the 5 wonderful, amazing days that I spent with my father in his dying days, I decided that I was going to be a hospice nurse. Part of it is to give what I never received when my father died, or how I wish he enjoyed the last days of his life. And so that has made me a better, if you like, a good hospice nurse to my patients, because I can tell what it was that I would have received that I never got, but I know how to fill the gap for my patients. And I'm happy to explain what hospice really is and what it's not. There's a lot of misconceptions out there, but yeah. I'm happy to.
And so you basically, when you decided to become an RN, this experience that you had with your father, watching him pass the last 5 days with you there and no hospice, that kind of gave you a passion for this. Is that right? What led you down that path?
Absolutely.
Okay.
So my father, I can discuss his diagnosis. He had a dental extraction, became complicated, and he pretty much had just 5 days to live. I was with him in hospital every day, and he struggled. It was painful to watch him go like that. He did not get the best of medical care. But knowing what I know about hospice today, he could have enjoyed quality as opposed to quantity of his life during those 5 days when medical science could no longer be there for him. And again, that's what hospice really is. Hospice philosophy supposes that everybody knows that death will happen to every individual at some point in their life. It's a given. And with hospice philosophy, it's all about the quality of the person's life in those dying days, as opposed to trying to elongate life. We do not hasten death, just like we do not also stop the disease progression in itself. It's all about giving the patient quality of life to enjoy what is left of their life.
So for me, and one thing that really excites me about this conversation is I really, even given the field I work in, I don't know a whole lot about hospice, but one adjective that comes to mind is comfort. One of you all's big goals is to comfort, make sure the individual who's going to be passing soon is comfortable. Is that correct?
Absolutely.
Okay.
So with hospice, the number one criteria is that the care team, the doctors who have been caring for this individual, for the patient, have determined that the life expectancy is less than 6 months. If the disease runs
less than 6 months.
Less than 6 months if the disease runs its normal course. So if you take any disease, say cancer, You've done chemotherapy, you've done radiotherapy, they've looked at all of the interventions they're putting in. They're not being helpful anymore.
Okay.
And if that disease continued to progress the way it was going, in less than 6 months, the patient will no longer be with us. At that point, someone has to make a decision. Do you want to manage the person's every discomfort this person is experiencing for the remaining 6 months,
Right.
or continue to subject the body to all these interventions that may or may not, and most times are no longer beneficial to the
Sure.
individual? And that's really what hospice tries to do, to provide comfort. And there are various ways to do that, but the focus of hospice is to make sure that the individual dies peacefully, enjoys the quality of their life, free from pain and discomfort in the last days.
And then is it also correct that one of the benefits of hospice is that, of course, the main focus is on the family member who's passing, but you guys also want to provide some comfort to the immediate family. Is that correct?
That's an important question you're asking, because I use myself as an example. When my father died, we didn't have hospice, but he passed. But what about us, the primary caregivers?
Right.
We were distraught. We were left by ourselves.
Yes.
His loved ones, his primary caregivers. But here, the hospice addresses both the dying patient and also the caregivers.
Okay.
We have a bereavement program to where we help the individual cope with an event as traumatic as the loved one passing. It's very traumatic for most people, and this benefit is available for about 13 months even after the individual passes.
That's wonderful.
With hospice care.
Okay, and then with hospice, so it's typically in a home type environment, is that correct? But it could be in a hospital environment if somebody needs to be hospitalized. Is that kind of how it works?
Yeah, again, that's a very brilliant question, an important one at that. There's a misconception about what hospice is. People think it's a physical space. So hospice is not a physical
You don't
space.
have a building where you go.
It's not a building.
Yeah.
It's a concept.
Okay.
So to that extent, you can enjoy hospice services in a hospital, in a long-term care facility, in a nursing home, in an assisted living facility, in a group home, and more importantly, in your own home.
Right.
Evidence-based practice shows that people tend to do well in their own home with loved ones, with family, in familiar environments. And so hospice can be provided anywhere the patient chooses.
And sometimes I think back to some people I've known in my life who particularly maybe have had a terminal diagnosis with cancer. Well, some people might even choose to go to a beach location, right? Some people will go to a place that's special to them and live out the remaining days. Have you seen that as well?
Again, that's related to what I said earlier about quality versus quantity. At that point, you want the individual to enjoy their life, whatever they enjoy doing that doesn't hurt them. You want them to continue to do that. So if it involves going to some exotic place you've always longed to, if we can pull that off based on the acuity level of their disease, that's great. Just it's about quality of life.
Got it.
Than as opposed to quantity.
And so if somebody needs home hospice, they qualify, they hire a hospice company. Is it 24/7? Is it round the clock? Somebody's always there with them. Is that correct?
Okay. So hospice service is provided 24/7 round the clock, but you don't necessarily have to have an individual in the home 24/7 because you also want to give family, caregiver, and patient some privacy as well. Yeah. Typically, there are team members in an interdisciplinary team that provide service to a hospice patient. So this would include a doctor, it would include nurses, social workers, chaplains, home health aides, bereavement coordinators, and volunteers. Right. So nurses would typically go to the patient's home average 3 times a week.
Okay.
I've seen twice a week, I've seen once a week, I've seen once every 2 weeks, but about 3 times a week. But there are different levels of hospice care. There's a point to where a patient's symptoms are no longer controlled by routine medication. Let's take, for instance, pain,
Yeah.
where the patient is taking routine medications and all of a sudden those medications are not cutting it. This happens especially with cancer patients.
Sure.
Now you have to pull out the big guns in what we call comfort medication.
Yeah.
And the patient has to be medicated pretty much round the clock
Okay.
to control that symptom. In that situation, you have to have somebody 24/7 sitting
Okay.
with the patient. Other than that, most other services are done on a case-by-case basis as needed.
Okay.
In the sense that they're scheduled to be done, and the patient still have time for their own personal private life.
So just kind of give me the typical scenario if I have a loved one who needs hospice, but let's say they're not yet to that real critical point. How many hours a day typically would somebody from the hospice company be in the home? Just kind of on average, 6 hours, 8 hours?
Okay, if a nurse makes scheduled routine visits to the patient, I would expect the nurse to spend minimum of 1 hour with the patient.
Per day?
Yes, per day. But of course, depending on the disease process and the acuity level of the patient.
Okay.
Some interventions may not require you to be there more than 1 hour.
Okay.
And 1 hour is typically enough to cover all the things, to hear from patient and caregivers what their concerns are, to do an objective assessment of the patient, to work out what your interventions would be, coordinate with the doctor, and make actual interventions with the patient. Typically 1 hour is it. In addition to the nurse, you also have the aide that comes over to the patient to help with activities of daily living, things like bathing, toileting, and
is that normally on a daily basis?
Depending on, again, the acuity level of the patient and how well these assessments are done during admission to determine how much care the patient will be needing. So if a patient needs daily visit by an aide to help them with the activities of daily living, it will be dailies. And the aide could spend anything from 1 hour to 2 hours, again, depending on the acuity level and the level of care the patient requires.
Okay, and can you explain to us something that I don't know what it is. I can just kind of make some educated guesses, but from the standpoint of hospice, what is a medical care kit?
I presume you're talking about a comfort kit.
Yes, correct.
It's called comfort kit. So these are, I call them the big guns, the medications that have to be medicated pretty much round the clock to get some symptoms under control. Because keep in mind, we said that with hospice, our goal is comfort, to make the patient as comfortable.
Not be in pain.
Not being in pain, or sometimes respiratory as well. You want to calm down the respiration and make them really comfortable. There are certain medications that you use to do that. So many of those medications are controlled. And so therefore they're not just routine medications that you have lying around the patient's home. They are usually tightly controlled medications, things like benzodiazepines,
painkillers,
strong opioid analgesics that are controlled. And because of the nature of these medications, you need a trained personnel, a trained nurse round the clock to administer those medications.
Because they can be dangerous.
Dangerous. There's a thin line between what can help and what can hurt the patient.
Absolutely.
Things as simple as just measuring the dosage of medication is very important. An untrained person might confuse 0.1 milligram and 1 milligram. And it could be fatal. So.
And then I heard you mention earlier, you mentioned about a chaplain. So it sounds like one aspect of home hospice is providing, if somebody wants it, some sort of religious comfort. And is that kind of extend to everybody? If somebody is a Catholic or a Muslim or a Hindu or a Protestant Christian, does that sort of, do y'all have different people of different faiths that you work with?
Yes. So human beings are by nature spiritual, some religious. We do have chaplains whose job it is during admission of this hospice patient to evaluate what religious needs there might be now and down the road.
Okay.
And their job is to find out what is important spiritually to the patient and prepare those resources as the patient transitions. So you might have a chaplain who's a Christian, but they know where to get resources in the community for, say, a Hindu
Okay.
or somebody of Jewish faith.
Yeah.
The chaplain's job is to identify those resources
Okay.
and have it ready. But depending on what the patient wants, some patients will actually say we really want to keep things private. We don't want involvement of any religious.
Okay.
But the ones that welcome it could be a Catholic priest if
Right.
that's a Roman Catholic. And yeah, so when that time comes, the chaplain would
Reach out to
resources,
somebody from that faith.
from that
Okay.
faith to provide succor to the patient.
Okay, and then you mentioned earlier, so it sounds like home hospice will help with things like eating, bathing, and dressing and those kind of things.
Right.
Okay.
Absolutely. Yeah.
And then that normally, obviously, that probably would not be a RN, right? That they would be sending in somebody else to help with those things, or is that an RN who would perform those duties?
So the way it's structured, an RN can provide his nursing job or her nursing job in addition to all these other jobs that can be provided by what we call a certified nurse aide or home health aide.
Okay.
These are unlicensed assistive personnel,
Okay.
but they are trained to provide activities of daily living.
Okay.
So things around cleaning, helping the patient with ambulation. If they're
Sure.
wheelchair bound, transfer them to wheelchair and help them get from point A to B in their homes. Feeding.
Sure.
And bathing and all those kinds of skills. And RN can do it as well, but we also have someone dedicated to that function.
Okay.
It's called a home health aide.
And I'm curious, so, do you see different things? I mean, so you're in somebody's home, normally they're pretty much confined to a room. Would that be correct? I mean, these are usually not somebody that can walk around and go different places. Are they normally confined to a certain room to a degree? How does that work?
No, but you cannot confine somebody who has an ability to move around either in their home or outside of their home.
Okay.
Okay, so every human being is a free agent,
Right.
depending on your abilities and your
Right.
acuity level. If the patient, say, you can have patients with things like COPD, end stage respiratory condition. There's nothing wrong with their legs. They can walk, they can cook.
So you might have somebody in hospice that are even they're going with their family to the store to eat dinner at a restaurant, but they could be in hospice.
Absolutely,
Okay.
There's nothing wrong with
Yeah,
that.
I just had this image of this bedridden person that just lays in bed all day.
Oh no,
Okay.
no. Again, hospice is not a place. It's a concept of the quality of care. If you look at some disease processes, say heart disease, you could be talking with a person today, everything is all fine, and they go to sleep at night and they don't make it in the morning. But we know based on how the disease has progressed that the heart is, for say congestive heart failure, that this heart is about to give up.
Okay.
And it could happen anytime, but it doesn't mean the person would necessarily be bedridden before then. They could pretty much have gone about their business today, and next moment they're gone.
Okay.
And hospice does not constrain them to a location.
Right.
As long as they're enjoying the quality of their life, then that's fine.
And then let's talk about this. So with pricing, let's talk about different options in terms of private pay. I know there's sometimes for certain individuals, Medicaid will pay. What does the pricing and the cost of hospice look like? Give us some examples.
Well, individuals can make their arrangement with hospice companies. Of course, there has to be a doctor's referral for hospice to evaluate the patient. So your doctor sends a referral to a hospice company to see if you qualify for hospice service.
So it has to come from a doctor's referral.
There must be a doctor's referral saying, hey, of course, after discussion with the family and saying, hey, at this point, I would suggest that we focus on quality as opposed to quantity of life. So with the doctor's referral and hospice evaluates and patient is qualifies for hospice, you can make payments in two ways. Either individual pay, individuals make this arrangement where they agree what they want to pay the hospice company, or for those that have Medicare, then that can also.
Okay, so it's Medicare. So Medicare has a program that will help cover the cost of that.
Will help cover the cost of that, and the Center for Medicare and Medicaid would serve as a supervisory agency for the hospice to be sure that quality determine that admission is.
So depending on if the individual is maybe in a nursing home type environment with Medicaid, or if they're on Medicare, it could be either of those agencies can help cover the cost.
Absolutely, because again, being in say in a nursing home, the room and board will be paid by the Medicaid.
Yes, right.
But the healthcare part will be paid by Medicare.
And then, are there ever scenarios where private health insurance pays for hospice, or is that pretty much always something that seems to be off the table that they don't cover?
No, they can cover that as well.
They can.
They can cover that as well. Yeah.
Okay. And so let me just kind of ask you ballpark. I mean, if somebody comes to you and says, look, we're just going to private pay. We're not going through insurance. We don't have Medicaid. We're just going to private pay. What's the average monthly cost, do you think, of hospice if somebody private pays?
I'll give you a range.
Yeah, give me a range. I'm sure. Fair enough.
From $4,000 to $5,000 to $4,000 to $6,000.
Okay, depending on their needs.
Depending on their needs, and of course, if they go to what we call crisis care, like I explained earlier, when their symptoms are not need to be controlled with routine round the clock medication and intervention, then that cost increases slightly. But routine hospice care, anything from $4,000 to $5,000 a month.
Okay. And guys, I want to let y'all know, I'm going to ask Reggie one more question that I think is absolutely fascinating to me. I don't know if you guys will think it is, but I'm really interested in this topic, and I have been since my own father passed very unexpectedly about 9 years ago. But guys, get your questions ready. If you have any questions for Reggie, feel free. You can't see Mitch, but he's on the other side over here with the computer. And so they can type in their questions. Is that right, Mitch?
Yes.
So if you guys have any questions, type them in. Mitch will read them, and then Reggie can answer them. Or if you have any estate planning questions, I can answer those. So, okay, one thing that I became very interested in, that really I had very little interest in before my father passed at the age of 64, super quick, super unexpectedly, is this idea of kind of evidence of, an afterlife, right? And when people pass away, and when people are in the process of passing away, I started reading a lot of different material, seeing different things on television, and Netflix. There's a good documentary right now about things that kind of would lead us to believe that there's evidence of the next life we're going to. Whatever our concept of that may be, it all can be very individual. But for those of us who do believe that we have a soul and it's going to move on someplace hopefully better, right? More peaceful. What kind of things have you seen in your years of working in hospice that you would think are interesting to tell other people?
Well, that's a very great question. When we train nurses to become hospice nurses, one of the questions we get many of the times is family members asking us when we think their loved one will pass.
Sure.
There are telltale signs that a good hospice nurse looks out for as indicators that death is imminent. One of those is when you see patients suddenly start either seeing or having conversations with deceased members of their family or friends or acquaintances. It usually indicates that death is imminent. In my practice, I've seen it several times to where the patient is mentioning some names and family members are like, oh, but that's granddad. Oh, that's my dad, my mom's sister that died 5 years ago. The patient constantly keeps talking about and having conversations with dead
And so it's
persons.
almost like they're literally having a conversation with somebody who to us is not there, but to
Right.
them,
They can see
it would appear as if that
Yeah.
person is there and they're communicating with
Absolutely.
them
And
in
I
the
have-
dialogue.
Right. I have
Okay.
a personal experience as well with my own father. He was not on hospice, but prior to when he died, his last few days, he was constantly seeing our dead relatives and family members, and he was calling their names and having conversations with them. At the time, I didn't understand why that was happening, but when I became a hospice nurse, I realized that that's part of the signs that death
Sure.
was imminent. Now, why does that happen? Why are they seeing the things they see? I don't know.
Yeah.
I've never been to that part
Right.
to tell, but
We could
it's
speculate
funny.
maybe they're kind of in between worlds, right? Potentially.
It is possible.
Right.
It is possible. And there are also a strange phenomenon I've seen in hospice as well with many of my patients to where someone seems to be hanging on to life, waiting for, say, a particular member of their family to arrive from, say, out of state before they pass. So every sign is showing that this person can possibly still be here with us because the body has shut down. But many times I see it as soon as that last child or their beloved child or their beloved brother or sister arrives from how many miles and hours out. As soon as they hold their hands, they smile and they go. So why does that happen? I don't know, but it's just an observation.
So they're able to kind of hang on until that loved one gets there, and then they feel okay to
it's
to
now
go.
free to go. Yeah.
And so for me, I didn't witness this, but my cousin did. And apparently my grandfather, a few years back, he died of congestive heart failure. My cousin was in the house with him when this was happening with his wife, who was an RN, and it was Christmas time. So they had a Christmas tree in the house. And I asked my cousin, hey, what was this like this last couple of days with our grandfather and watching him pass? Because we had all really looked up to him and been pretty close to him. And he said that he stood in front of the Christmas tree and had conversations with his parents, his siblings who had already passed, and his aunts and uncles who had already passed. And then a few hours later, he was gone. So that to you sounds very familiar.
Oh yeah. I wouldn't be. I won't make much of it now that I've seen it way too many times happen that way with hospice. And as a good hospice nurse, when I see that happening with a patient, as soon as I start saying those things, I tell the family that I think we're close.
Okay. And so just one last question, and then we'll see if some of the viewers have questions. But kind of tell us why, just kind of wrap it up here. If one of us that's watching this gets a terrible diagnosis tomorrow, or we have a family member who does, why is it good to go with hospice rather than to just simply rely on your family to take care of you? Why is hospice a good plan?
That's a good question. Let me give a quote from Dame Cicely Saunders. Dame Cicely Saunders is attributed to have found the very first modern hospice in about 1967. And she said, quote, "You matter because of who you are. You matter to the last moment of your life. And we will do all we can, not only to help you die peacefully, but also to live until you die." Again, this is for me, the heart of hospice philosophy.
Okay.
If you have a loved one who has suffered through illness and medical science has determined that their prognosis is less than 6 months, rather than subject the person to continuing, if you like, pain and discomfort and stressing of their bodies, if their doctor has determined that they have less than 6 months, it's best to enjoy quality
Yeah,
of
absolutely.
what's remaining, as opposed to continuing to put the body through, say,
Pain.
pain,
Right.
chemotherapy, radiotherapy,
Yeah.
and jumping from one place to the other. Hospice doctors have almost unlimited access to the tools and the skills required to make a patient that's in discomfort, to make him very comfortable. I mean, that's the whole focus of hospice. It's all about the quality of life. It's all about comfort,
right,
in those last days of life. And it's not just about the individual who's sick. Look at the family members. Many of them, many individuals never recover from losing a loved one.
So it takes a lot of stress off the family to have hospice.
Stress of the family members. They have the bereavement counselors who are trained in bereavement. People go through the 5 stages of life. It's been shown that those who don't have the hospice care take longer to complete their grief cycle. Whereas if you had the chaplain and the bereavement and volunteer working with you,
Yeah.
it's easy to close the loop and have a quality of life yourself.
Wonderful. Yeah, it's a very eloquent way of putting it. So that's great. So, hey, Mitch, do we have any questions for Reggie or myself?
We have 2. So the first one, what role does your private doctor have in prescribing care, or is it up to a nurse or hospice MD to manage all the care?
It's a great question.
Yeah, that's a great question. You want me to take one at a time, or I can take that real quick? Why?
Go ahead and take that one.
Right. So in hospice, every patient is still encouraged to keep your doctor. I mean, nobody takes your doctor away from you, but the way it works is the hospice doctor focuses on the main prognosis, the diagnosis for which your prognosis is less than 6 months. Say, for instance, you have a patient with end-stage cancer, but they also have other disease processes like, say, diabetes or COPD. The hospice doctor will focus primarily on the end-stage diagnosis of cancer, but you are still free to consult with your doctor, get your medications from your doctor. These doctors always harmonize their care. They talk to one another. However, I see most patients end up letting the hospice doctor be both their primary physician and the hospice physician. It makes sense because you don't, but nothing stops you from keeping your doctor and being managed for things that are not.
As long as you make sure that the 2 doctors are in communication and that kind of a thing.
Right. But when you start looking for aggressive treatment for the diagnosis for which you're on hospice, then you no longer qualify for hospice. But you can continue to treat your other comorbidities with your doctor, but as long as it's not the primary diagnosis for which you're on hospice.
Okay. The second question, I'm not 100% sure if I understand what's being asked. Said, would the patient be a DNR, or would they change their mind and want 911 called?
A good question.
That's a great question as well. It comes up a lot. Now, DNR do not resuscitate. It's preferable in hospice.
Yeah.
Think about it this way. So what goes into a resuscitation, the CPR?
Yeah.
Many times people...
There's trauma to the body.
The trauma to the body.
Yeah.
We're here talking about comfort and painless death and, making the individual really happy to live or die peacefully.
Yeah, a DNR, it almost seems antagonistic to hospice.
To hospice philosophy.
Right.
You're just stressing the body that you're supposed to make calm again. So, but if you want to keep if you want to be resuscitated, it's within your powers to so ask. And that if you have a DNR, you can always revoke it at any moment.
Right.
Like you can wake up now and say, now I revoke it. It doesn't, it's best if you don't have it to be in line with hospice philosophy. I mean, to have a DNR in place, but if you don't have it, you can still be serviced for hospice. Okay.
Was there a second part to that question?
That was
pretty much
all
it.
there was
Okay.
on that question. So-
Any other questions?
No, that is everything.
Okay. Well, hey guys, thank you so much for joining us. And Reggie, I want to thank you. That was
Thank
awesome. Very, very informative. You're very well spoken. And guys, just so you know, this will eventually end up on our Facebook page, and it will also end up on our YouTube channel, which is wildly popular. We've got 1 million. No, I'm kidding. But we do have a YouTube channel, and you should go subscribe to make us look more popular. But just keep in mind, if you have some friends or family that you think could benefit from watching this conversation, this interview with Reggie, again, direct them to our website, to our Facebook page, to our YouTube channel for the McGee Law Firm. And then here in the next few days, that will be up. But thank you guys so much for tuning in. We'll look forward to seeing you next time here in the next month or two. And again, Reggie, thanks so much. We appreciate it.
Thank you, and thank you for having me.
Thanks, guys.